All right, well, without further ado, I'll get this started here. So this isn't really the kickoff for this weekend, I guess, although this is the first formal event of our weekend. Is that right? Yeah? Well, oh, that's true, too. Yeah. And then we had the tree planting last night. So I'm Colin Durdane. I'm the new chair of the department here, which is just an incredible privilege and a little intimidating and daunting to step into the shoes of some people who have done so much and been so effective, like Alan and Dr. Keats and others as well. But this is not about me, so I'm going to make this brief. This is just, I'm here to introduce Alan, who is stepping down as chair and is going to be giving us this talk here today on how VUCA is impacting healthcare and radiology. And I guess just a few other quick thoughts. You know, just what a blessing it is to have Alan still here in the department as a former chair, with his wisdom and his commitment to, you know, doing things right for the people that are here and for the patients we serve. And grateful to have you and eager to hear what you have to say.
Thanks, Colin. I'm not stepping down. I've been down for a while. Colin, you took over on January 2nd. We've been very lucky about that. First of all, I want to thank all the alumni for coming back home to visit, so to speak. We have people all the way from Tacoma and Portland, Oregon, so it's good to see you. We even have someone who helped me when I was a fellow at Georgetown, and I was working there. He's married to someone that trained here, and he's here as a spouse, but Paul sort of held me up when I was a fellow at Georgetown trying to figure out how to do cases, so it's good to see you, Paul, as well. So what I'm going to do is talk to you about VUCA and how it's impacting healthcare and radiology. Who even knows what VUCA stands for? Okay. Minhaj, you would. Okay. These are my disclosures. But the additional disclosure is on April the 7th, I took over as chair of the American College of Radiology Board of Chancellors. But the views I'm going to express here are my own and are not necessarily reflective of UVA or Colin or the department or the ACR. A lot of what I'm going to bring up is going to raise some thoughts, get you to think about what's going on in healthcare and the world itself. So what I'd like to do is define the acronym VUCA and what it represents, discuss how we got here and why VUCA is affecting healthcare and the practice of radiology. And then, with my little bit of a bias in my new role, I want to talk to you about why it's important to be a member of the ACR more than ever, and for all radiologists, and actually for our field. Drew's nodding his head because he's been president of the Virginia chapter of radiology for a long time. So let's define what VUCA stands for. It's an acronym. V stands for volatility. We are seeing an increasing pace of change, and it's created a volatile world in which we're living. U is for uncertainty. It's lack of predictability of the future. C is complexity. I added the other C, chaos, because sometimes it feels really chaotic because things are moving not only inconsistently, but sometimes diametrically opposed, and sometimes it makes absolutely no sense about how things are connected. And the A stands for ambiguity, a lack of clear trends and stability. So the world is feeling like that. Healthcare is feeling like that because of that. I didn't come up with this term. It was an acronym that was first used in the U.S. Army War College in 1987. It was applied to conditions because there was so much volatility, uncertainty around the end of the Cold War and at the time of the conflict in Afghanistan. Later they published about it and talked a little bit about this topic. And then it was further popularized in 2008 when we went through our financial crisis, the so-called recession. And really who popularized it was the Harvard Business School. They published a review, a 4-part series on volatility, uncertainty, complexity, ambiguity. And in their publication, many of the tenets they put in there have become a standard resource for modern business leadership during times of uncertainty and change. Part of that Harvard Business Review article, they talked about when life is stable and transparent, having more data usually leads to better decisions. That's generally true. When life becomes turbulent and chaotic, access to reliable data can be elusive and at best sometimes murky and potentially misleading. So leadership during times of change often need to make decisions with a paucity of good data. Think about COVID when that hit. Many of us that were in leadership positions were sort of making decisions. We didn't have great data. We were acting a lot on intuition, what seemed to make sense. So in times of rapid change and volatility, uncertainty, complexity, chaos, and ambiguity, waiting for data can sometimes lead to passivity. Mission creep, because while you're waiting for data, people think of, well, it would be good to have other data, and things start changing, and then eventually potentially worse outcomes. So now I'd like to discuss how we got here and why VUCA is affecting healthcare and the practice of radiology. So let's talk about volatility and increasing pace of change. Noam Chomsky, a linguist and scholar, has this quote: if you're teaching today what you were 5 years ago, either the field is dead or you are. Okay, think about that. That's pretty dramatic. Why do you think he said that? Well, information is doubling about every 70 days. So that means if I started medical school today, by the time I finished medical school 4 years later, I'd have to know 1 million times more information than I started on day one. Does that feel overwhelming, just thinking about that? In his book, Thank You for Being Late, An Optimist's Guide to Thriving in the Age of Accelerations, Tom Friedman talked about the pace of data generation, information sharing has accelerated so quickly that it's become difficult for systems and people to manage. In there he says, fast has become so fast, slow now seems really slow. And we think about that. Even though we have access to all this information, we always feel like we're behind. Martek's law talks a little bit about the conundrum that this fast change has brought about. Technology is now developing at an exponential rate. It really started in about 2007, kicking up. What happened in 2007? The iPhone, exactly. You now had a computer that you could walk around, access information, data in real time, and Google became available, Twitter became available, information started flowing. That really changed things. Now, most organizations and most people can only advance and process things in a linear fashion. Think about that. In medicine particularly, Rubin published in JAMA in 2023 that it takes an average of 17 years for evidence-based data to change practice. And even then, only 1 in 5 evidence-based interventions make it to routine practice. 17 years. You're left behind in healthcare now because of the way information is flowing. This digital disruption, or I like to think about it as the digital divide, is creating volatility in the space of healthcare in the world today. You top that off with technology acceleration and your own personal mental bandwidth. We have a data deluge flowing in. People talk about, well, we're going to capture automated analytics and actionable decisions, code, AI, and help us function better. But our cognitive bandwidth is limited. There's only so much we can take before we start saying we can't deal with things. There's so much information, how do you process it? And ultimately, how do you unplug? There's this big crisis now that people are sleep deprived, right? And I think part of that is not being able to unplug, or feeling like you don't have the information you need to go forward so that you're being left behind. So you go to bed with a lot of things on your mind. Information sources are also adding to the volatility. What kind of things am I talking about? Social media, some of our friends. We get on our own individual echo chambers and polarized sources of news. Back when I was in my 20s, it was ABC, NBC, or CBS. Now you can find whatever you want to hear that just tells you what you want to hear to reinforce what you believe. Whether it's misinformation or disinformation, it just sort of gets you in this little echo chamber. Then you toss in religious and sectarian beliefs. Now, John Hyatt, he published an article called Righteous Mind, Why Good People Are Divided by Politics and Religion. And in there he talked about tribalism and sectarianism, that humans have a basic need to define and be on teams or in a camp. And they really defend their reputation more than the truth, often based on emotion and fear, rather than science and data. People talk about that. Emotion eats common sense and data for lunch. I just came back from Warsaw, Poland, and I thought about the death camps and concentration camps in Nazi Germany. A lot of that was driven by emotion and fear. If you look at that and you look at that history, it was not based on science and data. What about uncertainty, lack of predictability of the future? Well, COVID came and boy, did that shake us all up. I think it's going to be 2 generations before we realize what that's done to us. Then you throw in tornadoes, hurricanes, fires, whether they're in Canada or Hawaii, flooding from rains or mudslides from rains, or plastic bottles forming islands in the middle of the ocean. The World Health Organization says climate change is the single biggest health threat facing humanity. Yet what are we actually doing about that? Most of us see it, we believe it, but we don't know what to do about it. Now in this article and report, it tells not such a good story about health care and some uncertainty there. We're spending a lot of health care, particularly in the United States. This report says, Mirror 2021, reflecting poorly on health care in the U.S. compared to other high-income countries. Well, let's look at this. Healthcare system performance compared to spending. There is the United States, down that right lower quadrant. Higher healthcare spending, but also lower health system performance. Compare that to 10-country average, way up here. This is in the setting where national healthcare expenditure per capita in the last decade has increased almost 50% from 2013 to 2023. It's now costing us over $14,000 per life. And when you talk about over 300 million people, what it adds up to is we're spending twice as much as any other country that's close to us, and usually more than twice as much. We spend $4.7 trillion per year and about 18 cents on every dollar that our country operates, and we spend 1.4 times more than the entire gross domestic product of the United Kingdom on healthcare alone. Yet, let's look at somehow the data about how we're performing. Well, the U.S. has the highest rate of infant and maternal mortality. This is data from 2022. Let's look at infant mortality per 1,000 births. U.S. is 5.4. The OECD average is 4.1, 25% lower. OECD stands for Organization of Economic, essentially developed countries. There are 37 people that enter data in a cooperative to assess data like this from country to country. What about maternal mortality? The U.S., 23.8 per 1,000 live birth, per 100,000 live births. The OECD average is 9.8, 2.5 times the average of the other countries. Yet we're spending more than twice as much as the closest country near us. What about life expectancy in the U.S.? Look at the curve with the black stars on it. That's the U.S. life expectancy from 1980 to 2020, so 40 years. Right now, our average life expectancy in the US in 2020, that's about 3 years ago, is 77. Compared to OECD countries, more than 3 years less. And between 2020 and 2023, our life expectancies continue to decrease. Yet our expenditures for healthcare are going up. Well, what about uncertainty with our workforce shortages? It's a real conundrum. There's a mismatch between demand and supply. The total medical population has grown, Medicare population has grown 12% since 2017 alone. I'm a baby boomer. I'm adding to this. It's going to grow quicker. The number of diagnostic radiologists has only grown 1% in the same time period. So those of us that are in the workforce, yeah, it feels like we're working a lot harder because there's a lot more to do. The number of referring physicians has increased by greater than 2%. Radiologists only by 1% in the same time period. And the number of non-physician providers, also known as PAs and nurse practitioners, have exploded. There's almost, between the two of those, 400,000 of them. They order more studies per provider, particularly when they're in the hospital. As hospitalists, they're in the ED and they're in clinics. Our poor residents, when they're working at night, are reading so much more because we have NPs ordering stuff because they don't know any better. Plus, the distribution of workforce is not consistent with the needs. There's differences in job expectations as folks coming out. This is not judgmental, it's just the way it is. More people want to work remote, they want to work shifts, no call. The old idea of I stay there and I'll work until the stack is done, that's impossible because the boat is filling up faster than you can empty it. Okay? And then there are moral injury and burnout factors that are affecting workforce, and I'll talk very briefly about that in retirements as well. But the issue about non-physician providers is a real one. Many of us in this room may not know. Again, I'm in my role with the colleges, it's very evident. Besides ordering so much, guess what? Nurse practitioners are now starting interpreting imaging studies and billing for them independently. And when you ask them when they were trained, about 20% said, I've had no training. About another 20% said, well, I went down and spent 2 or 3 days in radiology. And maybe the other 50% said, I went on YouTube or spent a couple weeks. That's how they're learning how to read these studies. But between 2016 and 2020, it went up 27%. Well, you say, well, it's only 3.3%. It's 3.3% of the Medicare database. And what we've seen is less restricted states, those states, because licensure is state to state, it's not federal. There are 30 states, well, check that. A week ago, Oregon just approved independence of nurse practitioners as well. So there's 31 states where nurse practitioners can operate without the supervision of a physician. And those less restricted states have the greatest growth in reading of this. Now, what do you think they're reading? Plain films, ultrasound. Look at this data that came out of the Health Policy Institute. This is based upon over 3.3 million studies from 2016 to 2020, and it's only escalated since 2020. There's ultrasounds and radiography and fluoroscopy that comprise about 80%. But there's also CT. They're reading CTs and giving final reads. MRIs, they're reading MRs. And they're reading nuclear medicine studies. This is pretty scary. And at the same time, while radiologists recorded Medicare payment declines adjusting for inflation between 2005 and 2021, other physician providers, also known as NPs, PAs, saw their own collections leak nearly 206%. Now, budgetary Balanced Budget Act says we pay one provider $1 more, we got to pay somebody else $1 less. So that calculus, the congressional budget requirements, mean that any bump in income for one group affects other groups. And that's the challenge that we find when we're on the RUC committee, CPT. It's all a balanced budget. It's not increasing the pie, it's taking somebody else's pie away. Now, what about complexity, chaos, many moving parts, inconsistent connected parts and variables? I don't need to say anything here. We have an election coming up in November. Yep. And if you talk about uncertainty, volatility, chaos, complexity, ambiguity, it can become very much so this November, if not getting up to November. They add on to it cyber security and cyber attacks. Change Health is a major revenue cycle company. That means they process a lot of bills for organizations, UVA, other hospitals, smaller practices. They got attacked. And some larger health systems began losing more than $100 million a day because their claims could not be processed. It led the CEO of the American Hospital Association to make this quote, "We cannot say this more clearly. The Change Healthcare cyber attack is the most significant and consequential instance in its kind against U.S. healthcare system in history." Why? This is why. 94% of the hospitals have felt financial impact from the attack. 74% of hospitals reported direct effect on patient care. And when you think of some people being affected, $100 million systems, that's a good sum of money. They have to pay people. And smaller practice, smaller clinics, some are having to take out loans to pay their employees so they can get the bill until they can get their bills processed. The estimated impact on March 9th, now the attack occurred February 21st, so roughly a little over 2 weeks. It was already having an impact of $6.3 billion in healthcare of funds flow. Big deal. Now, what about at the personal level? Think about the increase in the health insurance premiums and workers' earnings. When you look at that, the red line represents health insurance premiums. The blue line represents workers' compensation. And between 1999 and 2016, premiums went up 203%. Workers' compensation went up 56%. And oh, by the way, with all the things that happened in healthcare, in 2014, that was a year when things flipped from you and I paying more than 50% of healthcare costs versus someone else paying it. So between our deductible plans, no longer being $250, but $10,000, paying our premiums, paying our co-pays, and paying our Medicare taxes, we are paying more than 50% of the cost of the health care. This has created a personal financial burden on a lot of people, blaming on health care costs, such that 1 in 6 Americans have past due health care bills on their credit report. In 2016, nearly 3/4 of Americans between the ages of 20 and 65 said they were insured but could not pay their health care bills. More than 1 in 6 individuals in the U.S. had medical debt in collections as of June 2020, and medical bills were the single largest cause of bankruptcy filings, and more than half of debtors had medical debts as part of their bankruptcy, and medical debt now outweighs all the personal debt in the U.S. So if you think about people are going to be really upset about health care, and they want it fixed because it's personally affecting them at a very personal level. It's also affecting healthcare companies. 73 healthcare companies, including 12 hospitals, folded in 2023. And since 2005, 192 rural hospitals closed. That's a big deal. That's only going to grow the healthcare inequities. How do we manage that? Healthcare is being disrupted, and so the health systems are consolidated and vertically integrated. Now that's very different than horizontally integrated. When UVA bought Culpeper, Prince William, and Haymarket, that's horizontal integration, right? We're just buying more bricks and mortar so patients can come see us. Vertical integration is a different ballgame. This is what it talks about. There's home health agencies, there's skilled nursing facilities, pharmacy, physicians, hospitals, and health plans, all falling under the same roof. So they interact with each other, with the big money makers being the health plan, pharmacies, and a little bit to the hospitals, and physicians and skilled nursing facilities being a mechanism so the other three can pour in the money. And it feeds back in, and patients are then, even though they think they have choices, they're told they have to go in network, otherwise they're going to have to pay more. So these consolidations and vertical integrations are really affecting healthcare and our businesses. And when you think about it, all major insurers are now vertically integrated with providers at the bottom, pharmacy components, pharmacy benefit managers, insurers at the top. And when we go across the top, you look at United Healthcare, Aetna, Blue Cross Blue Shield. You even see Walmart over there thinking about, we employ more people in the world, in the United States. One of our biggest overheads is going to be health insurance. Let's create Walmart Health, okay? And then you talk about these pharmacies. This is money making. If I can see patients in those clinics, keep them, we can keep all the money in house. And the provider service, Optum Care, for instance, employs over 30,000 physicians. Ascension employs over 49,000 physicians. Walmart recently on May 1st said, we're getting out of the health business, but we're still going to stay in pharmacies. This is how volatile this is. It was a year ago that they said they're going to get into this, and now they're folding already. But to put things in perspective, United Healthcare, Optum, Change Health are all one entity, right? They're worth more than $350 billion. UVA Health, even when we bought these other hospitals, we're maybe $3.5 billion at the most. Who's going to win when we get in a fight? 350 billion, 3.5 billion. This is why they're doing this. It's for influence. Independent physician practices are becoming more difficult to maintain because of this. Ali talked about it a little bit. You have to figure out how to manage all these dollars. Here's the ownership trends. The percent of physician practices owned by hospital, you can look in 2019 and go to the right to 2022. It went from about 24% to about 26.5%, maybe increased 10% over 3 years. What about the physician practices owned by corporate entities, also known as private equity, venture capitalists, things like that? Look what's happened in the last 3 years. It's almost doubled. This is from just 3 weeks ago. Nearly 78% of physicians are now employed by hospitals, health systems, or other corporate entities, according to data release. Now, think about this. This takes away what Arun would say our drive is, our autonomy, our purpose, and our mastery. Opportunities, because we become employees. About 3 in 5 medical doctors now work for a non-physician business owner. An investor. There's so much money in medicine. It's 18% of our GDP. Let's get in here and take some of that money. The number of radiologists now in private practice independently has fallen below 50% for the first time since the AMA started collecting data in 2012. What about ambiguity? Lack of clear trends. This is where I think the business of medicine has lost its way. We have a clash of cultures between the MHA and MBAs that have no clinical background versus physicians. And that's really driven by this no margin, no mission phrase. Who do you think came up with this message, no margin, no mission? It was a nun in the 1980s that was running a Catholic health system. Sister Irene Krauss. Interesting. And it's really about productivity and dollars, margin, over ideals and moral values as a physician mission. Therein lies what's a big difference with what's happening. The MBAs sniffed around for the dollars, $18 of every $100 that's spent in the US, and said, we have opportunity here. So look at 2022. Let's just think about some of this and drill down this a little bit more. 4.5 trillion was totally spent in 2022, 4.78 in 2023, 3.8 in 2019. Of this 4.5 in 2022, physicians and clinics spent accounted for about 20% of the cost. Look who accounted for about 56% of the cost. Hospitals and other health. Let's look at other health. and potentially hospitals. Retail drugs are over there to the left, maybe 9%. This is an article from JAMA that said nearly every industry in the U.S. has experienced substantial improvements in productivity over the last 50 years, with one major exception. Us, healthcare. In 2019, the U.S. spent an estimated $3.8 trillion in healthcare, of which 1/4 of that, $950 billion, was on non-clinical administrative functions. Go figure. Why do you think that happened? Well, let's look at healthcare administrators' growth versus physician growth. From 1975 to 2010, physicians grew about 150%. That's about how much the population grew. About 1-for-1, maybe a little behind. Look how much administrators grew in that same time period, 3,200%. Now, what do administrators do? They want to justify their existence, create more administrative tasks, which causes you to hire more administrators, and then puts burden on you and takes away from your ability to do what you want to do. It's sort of, to get that device in that you want to get in, it kills you, right? The U.S. spends 5 times more per capita than any other wealthy country on administrative costs. And there are CEOs and CFOs of health systems making more than $20 million a year. I saw one budget line from one health system. There were 10 different C people on that budget line, and all of them were making more than $10 million, and 3 of them were making more than $20 million. And immediately when they get in a room, they say, we're not meeting our budget, so we're going to make our nurses and doctors work harder. This is a problem. Healthcare economics, dynamics, it doesn't fit the supply and demand theory. It's very different. In supply and demand, the main interest party are the buyers and sellers. Healthcare is third-party insurers, government, and others. Supply and demand theory, buyers are good judges of what they get from sellers. We go online to Amazon, we know what we want, we like it, we don't like it. Patients often have no clue about what they need or what they're going to get. Buyers and sellers pay directly for the goods and services being exchanged, so they can be a judge of what, are they getting value for what they pay for. Healthcare providers are often paid not by the patients, right, but by payers in a non-linear fashion. It's very opaque. Again, talked about in the conference about this opaqueness of these charge codes and everything. Market prices are primarily the mechanism for coordinating market participants in the supply and demand theory, and the result is more efficient allocation of resources. In healthcare, the rules are established by CMS and insurers, and it really has nothing to do about true allocation of resources in the healthcare market, and it can be highly inefficient. And oh, by the way, on one side, things are happening quickly, and on the other side, we can't keep up. We just don't know how to do it. What about the effective margin on our academic mission? This is an article from Frank Lex and his colleague, Dr. Chen. Over the last few years, how often do you have to cut back on the following things because your clinical duties leave you inadequate time? Think about that. What about teaching, mentoring, publications, practice building, volunteering, CME, reading journals, and time away from work? The pink and yellow are always or frequently. Look at how many, teaching, it cuts into over 50% of the time. Research and publication, over 50% of the time. It's either always or frequently, not have enough time. This is a struggle with the mission and margin competition. And it's affecting our workforce because this productivity versus ideals and morals, it's causing moral injury. And I don't think it's really burnout. I just think any of us in the room could work 20 hours a day if we feel like we're doing a great service and great deed. In fact, we may go home after working 20 hours saying, what a great day. I did so much. But if you see yourself doing a lot of work that you think is, oh God, another inappropriately CTA of the head and neck, or what, you just feel like, why am I doing this? So moral injury describes the challenge of simultaneously knowing what care patients need, but being unable to provide it due to constraints that are beyond your control. So every time you walk home and you've worked 10 hard hours and you walk out and there's 40 MRs to read, you feel like you're disappointing someone. Your colleague, your chair, you're referring providers. And so even though you had a great day and you helped a lot of lives, you're morally distraught. I want to review why the ACR is more important than ever to all radiologists. Well, first of all, who is the ACR? A lot of people don't know who we are or what ACR is. It's more than 40,000 radiologists, radiation oncologists, interventional radiologists, nuclear medicine physicians, and medical physicists. There are 11,000 resident, fellow, and medical student members. Pretty robust, a lot of trainees. There are more than 500 staff. Now, we just let 11% of it go. That number used to be more than 550 staff. Okay? We have more than 2,250 volunteers donating their time, and we have 54 chapters. The governance structure is an executive branch with 32 board of chancellors. That's what I'm the chair of. That's what Arun's on. The ACR board provides leadership and strategic direction for the college and to implement the policy set forth by the council. We'll talk a little bit about what council steering committee and council and commissions do. The speaker and vice speaker chair the council steering committee. They're on the board, but the council steering committee and the council are the legislative branch. They make the policies. The ACR Council has 380 members, roughly, and they are representative of the 54 state chapters and the 24 subspecialty societies that qualify for council membership. There are more than 200 committees and 10 standing committees. The board chair is involved in choosing a lot of folks on that, but this is how the college operates. Now, I would submit that when you have volatility, uncertainty, complexity, chaos, and ambiguity, the college has that same VUCA. It has a vision, understanding what's needed, a clarity of vision, and adaptability. And why do I say that? These are programs and services, and those stars are the vision, understanding, clarity, and adaptability. The left column is member chapter support, in addition to the ACR annual meeting, but even under the member chapter support, there's the AMA delegate support. The AMA is critical. They set a lot of policies. The ACR has 8 seats to vote. There are over 300 specialties. Radiology is one of them. To have a seat is important because the AMA spends $20 million a year through advocacy. $20 million a year for advocacy. Compare that to the SAR. They spend $120,000 per year for advocacy. Whose voice do you think's louder? The ACR spends about $900,000 a year for advocacy. So even though the ACR is the biggest in radiology, it pales compared to the AMA. So we have to have a tight relationship. Now, I don't necessarily like everything the AMA does. That's part of compromise and bartering and working to try to get what you can get to support our specialty. That's critically important. The ACR supports the whole AMA radiology delegation. They also publish the JACR and ACR bulletin. These are things that membership dues pay for. Everything on that list, everything in green are things that have developed in the last 5 years, so it keeps expanding. Big thing is advocacy. Big deal. We formed partnerships and coalitions. The ACR initiated a coalition with 100 different organizations to fight for better Medicare physician fee schedule. Lobbying activities, political action activities, and they're heavily involved with the Relative Value Update Committee, CPT panel, payment models, economics, the Practical Expense Committee, and they work with the Medicaid and Medicare Advisory Group. And government relationships at the state, and they have a big advocacy network. No other organization does what the college does at that level in radiology. So people can say, well, you raised your dues, RSNA raised their dues. RSNA doesn't do what we do. AUR doesn't do what we do. SBI doesn't do what we do. SAR doesn't do what we do. Society Scale Radiology doesn't do what we do. SNMI doesn't do what we do. So this is critically important for folks to know. And roughly about 70% to 75% of dues go a lot to advocacy and government relationship. Have to have a strong voice for government. In fact, the ACR-led coalition, through advocacy, we were able to reclaim some of the potential cuts that were proposed by CMS between 2021 and 2023, resulting in, for radiology specialties alone, $1.64 billion that we would have otherwise lost. So being an ACR member, this is my pitch, it's basically your insurance policy for your profession. No other organization does what ACR does. When we look at education, for those of us in education, this RAD exam, DICSIT, are the in-service exam. The TICSIT is the RAD-ONC in-service exam. For those that are in private practice, the Ed Center and these Ed Center micro courses can teach you prostate MR, cardiac MR, breast 3D, it's there. And all of our residents live and love the AIRP, or for my generation, AFIP. And case in point, it's fun. It's a way to educate, a way to learn. And Radiology Teaches is a resource that we use to teach medical students, to introduce them to radiology. It's all there. The college does that and arranges that. RLI is really important. If you're going to change what's happening in healthcare, radiology has to be in more health system and national leadership roles. The only organization that does leadership training for radiology is the RLI. There are online courses, there are live events, there are resident fellow opportunities, there are scholarships to go. There's an annual one every year. It's very helpful for leadership growth. What about quality and safety, lung cancer screening? You just go down all these things, radiologyinfo.org. We do that in partnership with the RSNA. That's a patient education. Arun, how many hits are there now a month? 2.5 million. So, accreditation, all these other areas, clinical decision support, that started in 1993 so that people would learn to order the right test for the right reason at the right time. And Data Science Institute, Health Policy Institute are sources for generating data. This just happened in the last 10 years. And this whole DSI and informatics are critically important. This is the website for the ACR, your resource for strategic AI solutions. If you go up on the top, at the very top it says AI manufacturers, AI products that are FDA authorized. There's current AI landscape, talks about it, and it's broken down into subspecialties. So for those of you that are trying to keep up with what's available out there, what's reliable, what's safe, what's transparent, ACR has that. We provide workshops in conjunction with the FDA, and Christoph Wall just testified with this legislature about AI. So we're seen as a resource for the government. So all these different things ACR does. Now this is an interesting slide that you should be aware of, just for conversation purposes, for advocacy. This table shows that inpatient hospitals, skilled nursing facility, outpatient hospitals, and the consumer price index between 2001 and 2021 increased a little, right around 70%. The Medicare Economic Index, that is the cost of providing medical services, has gone up in that same time period, roughly about 50%. Physician compensation over that same time period has gone up 10%, and when you adjust it for inflation, physician compensation has actually gone down 26%. This is not sustainable for groups and hospitals that want to run a practice. So the ACR is advocating that a permanent reform is necessary rather than these short-term fixes every year and fighting. And we heard in February that there's a bipartisan group of senators that have formed to really brainstorm and work with our coalition to find an approach for fixing the flawed approach to physician payment. So ignoring all the benefits and focusing on ACR-led reclaim reimbursement, I point this one out in 2015, the Multiple Payment Physician Reduction Act. We were able to lobby to get this reduced from minus 25% to minus 5%. That has saved about $50 million for radiologists per year, or about $2,500 per radiologist per year. In 2021 to 2023, that savings of $1.637 billion probably saved radiologists about $46,000 per radiologist. And this last year, we were able, on March 9th, to get CMS to turn around the conversion factor reduction from 3.37 to 1.69. We don't know how much that's going to save. Now, we should all be aware, Florida is trying to implement this MPPR for studies ordered. So back in the days, it was CT spine, C-spine, T-spine, lumbar spine that got reduced. Now it's per study. So if they order a CT, an ultrasound, a nuke study on the same day, they're going to reduce payment for the different tests. So the ACR has picked up on that. They're going to advocate against it. They're also trying to bundle breast imaging exams. Now, for those of you that did breast imaging, prior to 2010, breast imaging was a losing proposition. With 2015, they increased payment for breast imaging. Breast imagers became a money maker. In the 30 years I've practiced radiology, the only consistent money maker there's been in 30 years has been neuroradiology. IR used to be a big money maker between the late 80s to about 2000. And then as they started bundling codes, IR, quote, became a loser, right? And so this is what happens with advocacy. There are winners and losers. But if you're not paying attention, you're going to get nailed. So what I say after this presentation is really embrace the Stockdale paradox. The Stockdale paradox provides an approach to navigating challenging and ambiguous times by confronting the brutal facts of your current reality while you maintain unwavering faith that you will prevail in the end, no matter how distant the end may seem. I summarize it by saying it's having persistent optimism tempered by realism that is informed by facts of your current situation. Now, Admiral Stockdale was an officer in the Vietnam War. He was in a prisoner of war camp for 7 years, and he witnessed many of his co-prisoners who died. And what he said was the difference was, I was optimistic, but heck, I was in this prisoner of war camp and I had no control over things. I didn't know when I was going to get out, but I knew I was going to get out. But he said many of the folks that were in prison with me would say, I know we're going to get out, and I'm sure we're going to be out by Christmas. And when they didn't get out by Christmas, they said, well, be sure I'm going to get out by Easter. When they didn't get out, they started giving up hope, and they just withered away. So he said, optimism with realism, but maintain that optimism. The optimism about radiology is an impactful specialty. Every clinical system, every clinical service in every healthcare system needs radiology service, and we impact so many patients every day. Even though we take up a big footprint, we're actually a financial moneymaker for a health system. That's the good part. Radiology's income still tends to be in the top 10. In fact, there's something that just came out and said we're number 6 of all specialists. There are plenty of jobs right now, as we know. You probably get called every week. Daddy, how many offers have you had in the last week? Probably 10. Physician specialties ranked by happiness. Radiology is number 11, so people are still pretty happy. So we have a great profession, we're impactful, we make a reasonable salary, and we're pretty happy in general, all things considered. So what I want to do is define what the acronym VUCA stood for, talk about how it's affecting healthcare, and review why the ACR is probably more important than ever to all radiologists. And now it's time to go have a little wine. Thank you. Any questions, comments, thoughts, additions? I don't know. Pari.
Do you know if with the NPs and PAs doing more independent imaging, what is the legal outlook for that?
So the college offers scholarships and or grants to states, which we have a heat map of everywhere where proposals are going forward. We call it our scope of practice heat map for NPs and PAs when they're asking for independence, basically to operate without the supervision of a physician. And so we are supporting local state chapters and AMA chapters because none of the physician groups are in favor of this. They want them to remain under the physicians, be called physician assistants. What happened in Oregon is they were able to get their names changed, the PAs. They're calling themselves PAs, but they're now called physician associates, not assistants. It's a very subtle change, but it takes them out of the rubric. So that's the big deal. So it's really about advocating, explain why, tell them about your 12 years of education since college to be able to practice as a radiologist versus 40% of them said, well, I went down and watched a radiology work for 3 days, and oh, by the way, I watched YouTube, so now I can read an MR. So other than that, it's politics. Minhaj, did you have any addition?
I actually had more of a question. When you said on the same lines, when you said they're interpreting their images, when you look at a clinic note and it's a billable event to say I independently interpreted the images or the EKG or whatever, the vitals, are you saying that they're actually interpreting and doing a full report on a CT scan that they've ordered, somebody scanned a patient?
No, somebody ordered, they read it, submitted a bill under their name.
I almost feel like that's not applicable based off of coding and reimbursement rules, but apparently it is.
But licensures, state by state, privileging, and all that. It's scary. I did not realize that until I started snooping around and it's part of my role.
Well, it is scary. The question I had for you is, I noticed the slide with the administrators going up and the physicians staying the same. What's going to happen in the future? I mean, what can we do to mitigate that trend?
Well, it's really about your sphere of concern and your sphere of influence, right? And over the years, physicians just thought, I'll do the right thing, I'll work hard, things will take care of themselves, right? And the MBAs who come in or the finance people that come in and say, I see an opportunity to take money out of the system. They managed to get leadership roles. To some extent, physicians took their eye off the ball. There used to be a number of hospitals that were called doctors' hospitals, especially down in Florida. Many of them got bought out by HCA, but we need to educate and get physicians in more health system leadership roles, legislative leadership roles, take some of it back, essentially. That's going to take time. So folks like Arun that wants to become a CEO of a hospital, we need to get behind him, go like this. Give him the opportunity so that he can get in there and sort of help change the back a little bit so it's more balanced. So Arun.
I don't want to follow that one. So in your position, having served as a chair of a department for many years successfully, seeing this health system grow, and now serving as the chair of the society that oversees our entire specialty, what do you see as the biggest threat to the continued success of the specialty of radiology in the House of Medicine?
Right now, it is the workforce. We can't keep up with it. The boat is filling up with the water so fast, and we're bailing as fast as we can. We don't have enough providers. And like what's happened in England, where all the plain films and probably 90% of ultrasounds are being read by technologists, right? Because they can't keep up with the CTs and MRs, no less the plain films. I think that's the biggest threat, because where there's a void, it'll get filled. And as we know from, when our reports go more than 24 hours for the docs that send them in from outside, they don't care. They'll give up the quality so they can get a report. The ED doc would rather have a wrong report than no report. And that's why I think the way our health system's set up, that's why the U.S. quality comparing to other countries is disappointingly low, yet we spend all this money because we're inappropriately incentivized.
Yeah. Alan, you want to say something about the ACR efforts for the decision support, I mean, that sounded like a promising avenue this last meeting.
So for those of you, the decision support is based upon the ACR appropriate criteria. K.K. Wallace, who was the first University of Virginia chair of the Board of Chancellors, I'm the second one, led that effort back in 1993. And it was designed really so that we can help people figure out what study to order as technology was growing more appropriately to do the right test for the right person at the right time. It was incorporated into the Protecting Access to Medicare Act, PAMA 2014, with the idea that it would be implemented and people that placed orders that didn't follow the CDS rules would potentially get penalized. But the way they wanted to implement it was real-time, getting approval and getting a code number and all that. And so CMS couldn't figure out how to implement, so they kept delaying to the point now we don't have enough physicians. Docs are complaining about burnout. The electronic health record has become so arduous that they put PAMA on hold, and as part of that PAMA is the clinical decision support process. So the ACR has been advocating that we agree the way CMS wanted to implement it was ridiculous. So what we're proposing is some edits to how they're going to implement it by doing a retrospective review of the ordering providers and whether they attested to use it, and then review them whether they use the CDS tool. Now, the CDS tool is only probably appropriate for about 80% of studies. There's probably 20% of studies you go to and it just doesn't quite fit. All they want to see is you went to it and used it. And that if you get a red score, meaning an inappropriate score, that maybe you adjust it, but you don't always have to get a score if it's not applicable, and you can document that. And we've seen that here as well. So the college has gone, and that was part of the lobby day that Colin was talking about, and Arun and Drew and others were there for lobbying to ask the legislatures to consider implementing the utilization management tool based upon appropriate use criteria that's called the clinical decision support order entry tool. And that's where the Moran company came in and said if they did it the way we're recommending, it would save government $2 billion over 10 years, and you and me get the test done on ourselves, $1.4 billion. So the way we were selling is, we'll get rid of excess studies. We're going to save the government money. We're going to save the patient money. It's like a triple winner. And I think that's how you have to play it. You have to see how you can put money back in their pocket. And hopefully they'll bite. We're working on that, but it's that advocacy that everybody was on Capitol Hill advocating for that.
I've got a question from the chat from
Okay.
Dr. Bueno. Is there any place for physician associates interpreting images in under-resourced areas where the shortage of radiologists is even greater due to geographic location? Not necessarily advocating for it, but wondering the position of the college in providing solutions.
So here's the position of the college. What we don't want to do is cause harm. We know from the Hattiesburg experience where they didn't have enough physicians to support a clinic in Hattiesburg, Mississippi, they staffed it with NPs. And 20 years later, what they found from that is number one, healthcare outcomes were actually worse. Two, costs actually went up because they ordered more tests, more consults, and more referrals. And interestingly enough, those patients that were going to the Hattiesburg clinic that had no doctors versus had an NP as their provider used the emergency room more. Okay? So that experiment proved to be a loser. It was actually more expensive, worse outcomes, and more costly. That's redundant. More expensive and worse outcomes. Now, the other thing we've noticed in the distribution of these so-called physician extenders, the intent was for them to go into underserved areas. They're not going to underserved areas more than physicians. They're actually, once they get out, they end up practicing in Newport Beach, New York City. They don't go to the underserved zip codes any more than the physicians do. So even though that's the theoretical benefit, when you look at the data, their distribution is no different than physicians. and they don't go out there. So I would say the college position is that no, we're not supportive of it at this moment in time because we've only seen data that actually says there's worse outcomes and it's more costly. Although, as I said, I'm not speaking on behalf of college during this talk. Michael, did you have something you want to say? Or? Okay, all right. All right. Paul, does this resonate with you? Or? So the question that Paul asked is, what about opening more residence slots so we can get the workforce up and going? Well, this deals with the 1997 Sustainable Growth Act that they assigned a number of residence slots for CMS to pay, and unless you start a brand new hospital in an underserved area, you can't get incremental positions because of the fixed bundle of dollars. Now, there is advocacy as part of this that we went to advocate on Capitol Hill to support a particular bill to increase the number of residence slots by 14,000 over the next 7 years, 2,000 per year, recognizing there may be some preference to underserved areas, hoping that they would stay in those underserved areas to work. But that is going before Congress now. But it all has to do with money. CMS has a lot more money for it. Because like whether it's at Duke where you're at, where you and Lisa are, you're already over the cap. Like at UVA, we're already over the cap. So either the department's paying for the extra residents or the hospital's paying for it. And therein lies the problem. But there's a little bit of game to this because in addition to the money they get for these GME slots, which is called direct dollars, you get indirect dollars. So because you're expected to be a little less efficient than without having to work with a trainee, the hospital gets indirect dollars. So they end up making a little money by having the trainees here. So it's a little bit of push and pull. Now, we put in a proposal to expand our residency position here. Juliana knows that because she's worked with me on this. Mike Hanley before her, worked on this. The problem we have is every service says they don't have enough residents. Medicine, family medicine, orthopedics, you go down the list. Everybody's asking for more. So we said we could afford it, we'll pay for ourselves. They still wouldn't let us do it because they said just because you have more money doesn't mean you should get it over family medicine. So they just said no to everybody. Go figure, but we figured out a little different way to finesse it. So, but we were able to get something changed for what appeared to be the same. But that's the kind of game you have to play. But that's Juan and Parvi.
So Alan, you're saying that even if we wanted to pay for services, we could?
Here at UVA, because it has to officially be approved by the CEO of the hospital. You know, we also have to get the GME office to approve it here to apply to ACGME. So once they're approved, then we have to get how we're going to pay for approved. But we got all those approved, but they just said no.
So, Alan, what's the solution to private equity incursion into private buying up practices?
So we'll end on that question. I don't have an answer for it. I think part of it is you know, just this past week, the non-compete clauses were, quote, eliminated for for-profit entities and maybe for non-profit entities. If that actually goes through, it's probably going to affect private equity more than others. Okay, that's one. So that if that actually gets upheld, I don't know if it's going to get upheld, but it's probably going to affect them. And beyond that, I don't know, because right now they're buying out things, and a lot of, it's interesting, I was going to put up a slide. We have a slide where we polled trainees, the ACR polled trainees, and said, are you concerned about private equity or your group being purchased? interestingly enough, 9% already said they were taking a job with a private equity firm when they answered the question, and 19% said, I have no concerns. So 28% of people coming out now, it goes over their head, they don't care. So I don't know.
Thank you.
Yeah, that's why I said I would bring up a lot of topics to get people thinking. I don't have any answers. I'm really pretty. And last one, so that you can get over to Mrs.
It's not a
Keats.
question. I'm just saying, optimism, 72% do care.
Yes, yeah, optimism. Okay, good. We like your so live by the Stockdale paradox. There's still, I mean, we still have, I honestly can look medical students in the eye. We still have the best specialty in medicine. We can have as much patient contact we want for those of us who love patient. And if you don't like patient contact, you don't have to have it. Okay? We touch more lives on a daily basis than anybody else. We have the coolest technology that's always evolving. And you can get into leadership, or you can develop things. You can help workflow. There's no other specialty that touches medicine the way we touch it. It's still the best specialty of all. So that I'm not just saying that. I truly believe it. And oh, by the way, we can all play our violin or whatever. We're still pretty well paid. I mean, the NPs and PAs are not getting paid more than some of our pediatricians. You know, if you want to sort of feel sorry for someone. But we're still okay, you know. Thank you.
Thank you.